We now go for the next speaker, Dr. Pang Yung, and Dr. Pang Yung General Hospital from Singapore. And his topic is versatility of unilateral biportal endoscopy in lumbar spine. Welcome.
Good afternoon, everyone. Can you all see my slides?
Yes.
Greetings, I'm Dr. Pang Hong Wu. I would like to thank the French Endoscopic Spine Surgery Society and ISUBE for the opportunity to speak on my topic of versatility of UBE in lumbar spine. This is my acknowledgement. I learned most of my uniportal and biportal skill from South Korea and my conflict of interest. Just a brief introduction. I'm a consultant orthopedic spine surgeon practicing in Jurong Health, a part of a National University Health System, Singapore. I take care of about 12% of Singapore's population, and my subspecialty interest is endoscopic spine surgery. I practice a hybrid uniportal and biportal surgery. 60% of my practice is uniportal and 40% is biportal. Ranges from stenosis, decompression, fusion, discectomy, as well as cervical and thoracic cases. So there's a modern development of UBE as the floating technique has been there for the past about 15 to 20 years. There are different terminology in the literature. UBE as unilateral biportal endoscopy started being named by the neurosurgeon in South Korea. And several papers are also have a similar technique, which is called biportal endoscopic spine surgery. They call it BESS. They are developed from the orthopedic surgeon in South Korea. I think the key difference is the use of osteotome. I think in the BESS way of doing biportal, they use a bit more osteotome than the UBE. So Dr. Soliman also named it as irritation endoscopic decompression laminotomy, and they published in Spine Journal. What I like about biportal is that it is a very versatile technique, and you can basically stand in the same similar position of left hand holding, if you are right-handed dominant, left hand holding viewing ports and right hand holding various working instruments such as kerrison, drill, osteotome, etc. And you can stand on different parts of the anatomy and perform effective surgeries. It is essentially a floating technique. The benefits to the patient is enormous. Irrigation surgery decreased view as a floating technique shows a very familiar anatomy that we show in our microscopic surgery. And it has a less limitation space that we required. We have a free 3D scoping and handling of instruments, and have a similar highly magnified view of uniportal surgery. Can be 30 to 40 times of structures. And at the same time, we can use ordinary similar spine instruments with minor modifications to open surgery, and hence probably can flatten the learning curve of endoscopy. You also benefit to the surgeons. We have the training, especially in orthopedic, in arthroscopy, just like Professor Loeck mentioned, is similar to acromioplasty in shoulder scope. And in neurosurgeon, they do transphenoidal scopic pituitary resection. We maintain the upright posture is probably better for us in terms of spine health, especially cervical spine health. It provides ergonomic visualization. It can be enhanced by, as we get older, you can see clearly, you can increase the TV size and have a better 3D, 4D level of high definition TV. We can engage assistants who can retract, and you can see from Professor Zhang and Dr. Song's assistant, they did perfect retraction and make surgery so seamlessly easy to do. With the familiarity of instruments, make us less anxious when doing this surgery. There are some weak points. I think, as you can see, we tend to might have difficulty in triangulation and some soft tissue bleeding. With more experience, this blurring of vision is getting less common. We know where the bleeding spots are, tend to be soft foraminal bleeding, and Bones, as well as other radio frequency company, provides good solutions to these bleeding spots. One important aspect in management of outflow by having the working portal to be sufficiently open to let water to be coming out. In uniportal surgery, there's an inflow and outflow channel, so that is taken care of. But in biportal, we need to make a conscious effort to keep the outflow going. Why do we need minimally invasive surgery when traditional open surgery yield good clinical results? Now, as we know, COVID-19 is the new normal. The situation is evolving. There are periods of time, especially in my country as well, where elective cases which require inpatient admission will be cancelled. So day surgery ambulatory procedure are allowed to proceed. And I find that in my own experience that we converted both uniportal and biportal endoscopic surgeries to ambulatory spine surgery where they are mainly staying less than 23 hours, and we are allowed to proceed and clear our elective workload. So in this new normal, we need to conserve hospital beds and also conserve the ICU as well as high dependency wards. So it is kind of what I wrote up as it has shifted from patients' benefits to public interest to perform minimally invasive surgery. And as you can see from my patients, the post-op care is pretty straightforward. This is about 4 hours after surgery, and they are already ambulatory, walking shown to be by my physiotherapists and ready for discharge. And I've seen another patient taking selfie as I walk towards him. No complex protocol on blood transfusion, blood taking, wound check during these first 2 weeks of post-operation. This is another patient. This patient have undergone cervical endoscopic decompression and discectomy, this post-surgery. And a few hours later, you can see them being cheerful and already ambulator, having very good function and has gone back to work. So we can achieve very short hospital stay in open spine decompression and fusion. And it has literature has shown several ERAS protocol that requires somewhat quite complex protocol from the pre-hospital phase to a post-discharge phase. In UBE, I find we just need to have a physio and pre-op counseling for same-day discharge. In post-op, I don't personally use any drain, so those teachers mobilize them on the same day for decompression, and I mobilize them for the next day for fusion, and most of my cases can go home within 23 hours. There's not much need to inspect 1 cm wounds, so I do not need to wound inspect, and I tend to not remove the dressing until 2 weeks. So far, touch wood, no wound infection, and I now have moved on and do not use any stitches on the superficial skin. I use this style of skin closure device. We call it skin close. Is imported by us to actually close the skin without stitches. And in my own personal early series, I find that both uniportal and biportal, in terms of wound and conditions treated, have a quite comparable good and comparable clinical outcomes. And we are gaining popularity in terms of both the uniportal and biportal endoscopic spine surgery, and people are in the spine community realize that it is important to provide minimally invasive surgery, and increasingly in multiple spine forum, we had endoscopic spine surgery occupy a session, as we can see here in the recent global spine, also held by French. Thanks for their enthusiasm in endoscopic surgery. AO Spine also wrote up a consensus paper to basically streamline the nomenclature, and UBE is listed as shown here. So what are the main differences in biportal and uniportal surgery? Being an academic cluster for advancement of surgical technique, academic results, research, I do both surgery. Personally, I find that they are pretty similar in terms of clinical results. And I published them in several papers showing the differences in the uniportal, and also raising up the challenges in the learning curve. Personally, in training and as well as training my other colleagues, I find that biportal surgery has a less steep learning curve, and they tend to be able to pick up the surgery faster and provide safety as well as effective surgery earlier than uniportal surgery. So in my mind, there's an endoscopic ladder of competence progression model, and starting from the left-sided L45 for UBE, and then subsequently maybe they can, once they're familiar, doing extraforaminal and right-sided UBE, and then subsequently go to the cervical first before thoracic as well as fusion. So I just have a discussion on the approaches to the lumbar spine. UBE, like uniportal surgery, and approach through the interlaminar, contralateral, and farlateral approach. Today, Professor Zhang has already shown us how to do the interlaminar as well as contralateral approach. There's another farlateral approach which is quite similar to what Professor Korichi Sayo showed us just now, which is transforaminal approach. And there's also an endoscopic fusion, which is have a standard U leaf as well as a recently popular XT leaf, which put in larger cages. There's also versatility beyond the approach itself. For example, you can do an interlaminar approach and then a contralateral approach, and then go further, decompress the central and lateral recess, and then go even further to decompress the foramen on the contralateral side. You can also use a 30-degree scope and also decompress more using curved osteotome, for example, to ipsilateral side foramen. So I just show some examples. This is an interlaminar approach. I'm going to write it up in a textbook, and it's going to be published. There is a two slight difference in UBE and best skin incision in my own reading and opinion. I've tried both of them. Basically, in the best system, that is a little bit closer to the midline, and the working viewing portal tend to be a little bit closer compared to UBE, which is the incisions is made in the medial pedicle line. This is a sequence of how we do the fluoroscopy to combine. You mark this level and the working portal. We triangulate nicely, and then we put in the scope subsequently. I tend to also, before I drill, do another X-ray to confirm the level, and then I drill and mark it so that I can take that as a reference in my endoscopic procedure. I think the biportal surgery, being a floating technique, allow us to use multiple portals as well, as long as we are familiar with the principle. First, if we put a viewing portal, we try to minimize bone obstruction to the viewing portal so that we do not need to get rid of a lot of bone before we get into the interlaminar space. Second, we need a 2.5 to 3 cm gap between the viewing and working portal so that there won't be a congestion of scope, or what the Korean like to call it, fighting between the working instrument as well as the scope. We also can minimize the bone resection required for when we put the working portal closer to the surgical sites, for example, contralaminar or the SAP, so that we can facilitate an infusion in line with this level so that we can facilitate the process of surgery. Having the working portal close, being parallel, also allow us to have a favorable working angle for instruments. This is a video of our discectomy, interlaminar discectomy. I hope it's playing well for you. Basically, a 60-year-old with a severe pain in the left leg radiating to the left posterior thigh. He has an L5S1 left-sided paracentral disc. The portals are made, and then we can basically, for me, we can do either ligamentum preservation. In this case, I remove the ligamentum flavum. There are people, nowadays, I tend to just remove similar to uniportal surgery. And you can see there's a pretty good view of the interlaminar pulsing nerve root and at this level. You can now engage your assistants to retract the nerve root, expose the disc using an Indian knife, and you can basically remove the disc effectively before you perform hemostasis and closure. And then next in the next ladder, we talk about the stenosis decompression. We start making a spinolaminar junction base cam. This is a video that you have seen before. After we mark the level, we perform making the base cam. We visualize the spinolaminar junction, and then subsequently mark using an X-ray, and then I drill the level. Perform a cathalact laminotomy essentially going upwards and laterally exposing the midline cleft, which is between the two flavum. There will be some bleeding superficial vessel, which you can use the Bones or other companies' radiofrequency ablation to stop the bleeding. And then you define the caudal lamina first. I tend to do that. Also, as I mentioned earlier on, I trim this spinous process of the caudal lamina so that I create more working space, lift up the ligamentum flavum, the superficial and deep layer, I separate it out. This is something that we can do in biportal, and uniportal is more challenging. In uniportal, if I do this, I have to really drill the superficial flavum off and use basically a forceps and pull off the superficial flavum. In biportal, we just use a curette and you can separate them. Now we can see that we are going contralateral side. I tend to use the osteotome, and Dr. Zhang Wei showed us that he used the Kerrison very well using this approach. And then we do the Catholic laminotomy, contralateral side. You can use a drill. I use the drill quite often here, and in this case, I just use the osteotome. I think it's just personal preference, and I see whichever is more convenient, and I do that. Subsequently, we will do the ipsilateral flavectomy followed by contralateral flavectomy. I mean, when I do uniportal, I tend to do contralateral first, so that I can visualize better when I do the ipsilateral flavectomy. I think there's no difference between the two techniques. I think you can do pretty well doing either way. But in biportal, I tend to do the ipsilateral first, so I create some space before I remove the contralateral ligamentum flavum. You can use the forceps for the contralateral ligamentum flavum. I think that is quite a safe approach. Now you can see the traversing and exiting nerve root. There tends to be some bleeding around the discal area, I think, and axillary area. So which Dr. DJ Choice call a crossing vein over this area. It's a good anatomical landmark for distal, enough distal resection. Now we remove the caudal lamina, top part of caudal lamina, and then you can see this is the beauty of biportal surgery. You can use a forceps and easily remove the contralateral flavum by plugging them out. And it's very safe because you are above the plane of dura. If you want to be extra careful, you can use upward pointing for forceps, and it's even safer. And then finally, you can use osteotome, you can use Kerrison, you can use a curved Kerrison like Dr. Zhang will show for contralateral SAP resection. I use a osteotome for that, and then we remove the contralateral ligamentum flavum. Okay, sorry for a lengthy video. I think two level I'm not going to show is pretty similar. The only difference is that you need to make another portal. The working portal becomes the viewing portal. And then the far lateral approach is this is the L45 left side. Basically, we call it P+2 or P+3. So lateral aspect of pedicle, and then you go to the +2 or 3 cm of the pedicle to depending on size of the patient, and then you can get to the far lateral. Eventually, the view looks somewhat similar to transforaminal or steep angle approach to a transforaminal uniportal approach. This is how we do it. So basically, I think in the paracentral or far lateral approach, there tends to be a bit more soft tissue than the interlaminar approach. The muscles are more robust in this area, and we need to be very careful not to go underneath the TP and breach the transverse membrane, transverse process membrane, which can lead to our saline fluid in the peritoneum. So we need to be very careful. There's also another being careful thing about this is the radicular artery is close by. It's a floating technique. I tend to retract them away and then resect the SAP. As you can see, we are digging under the ventral lateral aspect of the SAP. You can use the osteotome to get rid of it. You can also use a drill. Really no difference between how you do it. Essentially, after you identify you may see the exiting nerve root after that, or you may not, depending on how tight is that foramen. I like biportal when there's a lot of bone that you need to resect, because you can just use osteotome and knock them out, rather than in uniportal I have to really drill for quite a prolonged period of time. But essentially, it's whichever technique that you feel best for your patient. Essentially, it is what it is, and then after you identify the exiting nerve root, which you can see I'm pushing it out, it's a floating technique, so you tend to relax the nerve root retraction a bit. You are not using a working tube directly on the nerve root, pushing it away, causing potentially a dorsal root ganglion paresthesia. you push it away and then you make a small incision and take out this blue dye. I still tend to use blue dye even when I do biportal surgery. I know this is what I've been doing in my uniportal transforaminal surgery. So after you make a discectomy for extraforaminal disc, then you can retrieve the disc pretty well. Yeah, as you can see here. For the interest of time, I will move on. I would skip this. This is basically showing a decompression instead of discectomy. And then I think Professor Zhang will show a very nice contralateral approach. Just show briefly. Essentially, you can preserve the ipsilateral ligamentum flavum. You use a lower port, slightly lower portal, so you can get to the easier to get to the foramen on the contralateral side. I think Professor Zhang will show earlier on, he used a 30-degree scope. I used a 0-degree scope. The difference is not much, but if you use a 0-degree scope, then you tend to remove a little bit more bone so that, and whatever you have seen directly in front of you, you probably have decompressed already. So you can see that we are trying to get through the base of the spinous process of the cephalic lamina, which in this case would be the L4. And then you can get to the contralateral side. Sorry for the lengthy video. And then there's this landmark that you can do. They tend to be a little bit, there tend to be this sharp corner marks the midline. Then you get the more contralateral laminotomy to the cranial attachment of the ligamentum flavum. The ligamentum flavum attached quite laterally towards the pedicle. So you got to use a curette, or you can use the kerrison to get rid of the ligamentum flavum. And now resecting the SAP, which is similar to my technique, but I am more expensive here. That means I'm going more lateral than what I did last time. And removing, using a curve or straight kerrison, the superior articular process. And you can see the blue dye. I still use blue dye and then mark this and perform a discectomy. In this case, I didn't need to expose the existing nerve through L4 contralaterally. There wasn't a huge disc to remove. I'm just doing final completion of some of the osteotomy, and then you can get to quite lateral aspect of the to decompress the foramen and extraforaminal region. For the interest of time, I'm moving on to the next slide. So I published that as a uniportal, interestingly, contralateral approach, but I used a similar strategy for biportal. The main difference is really how much bone work you think that you need. If you really need to remove a lot of bone, I like, as I said before, biportal, so that I can use osteotome and quickly knock off those bones. And while in uniportal, I may have to do a little bit longer, but the results are similar. And finally, just a bit of the endoscopic fusion. I think this one it will be covered by a lot of our colleagues. And then this positioning, we tend to make the incision. I tend to make it horizontal on the pedicle. On the right side, we tend to be a bit lower so that the working port can be directly parallel to the end plate. I find that insertion of cage is easier. I published this in the as a inside our outside-in technique as a uniportal way of approach with Professor Hugh Song Kim. We label it Kim's point and Wu's point. I think basically if you move from medial to lateral, then in this study, when we use uniportal technique, we find that from outside going in is faster than the inside going out, but clinical results are similar. So this basically showing basically our incisions and then the cage trial. You can see from biportal surgery they're independent. The discectomy can be I use a working retractor. I do not be so dependent on my assistant. I do not have the fortunate opportunity or Harry's and different resident may be scrubbing with me, so I tend to use a working retractor that is transparent so that I can retract the nerve root and prepare the disc. You can get pretty good which is pretty similar to what we can do with uniportal transversatal resection approach. After that, you have to prepare adequately the disc. You can see you can insert the cage using from the cage. It's a PEEK cage, and you can see that it's inserted nicely in the central area of the intervertebral space. And then we put in the screws. Interestingly, I did both uniportal and biportal. Most of my patients, despite not having a drain, they are ambulatory the next day, and a lot of them discharged the next day afternoon. So, I mean, I do not have a huge series, but and the results are early. I find that it is quite so far in a 1.5 year follow up, they're doing pretty well. Finally, I will skip this for the interest of time. You can do bilateral. I mean, you can do more than one level fusion, and these are various papers that we wrote up for endoscopic fusion. In conclusions, UBE is a versatile and can be applied to most clinical situations for degenerative lumbar spinal conditions. Basic principle must be applied: creation of submuscular space, creation of subosseous space, followed by bony decompression, flavum resection, hemostasis, and then check for neural decompression. There are new approaches, and it's very exciting. I think Dr. Zhang shows us the third portal, the opposite side. You can make a quarterback portals to flow better, or you want to do a dural repair or annular repair, annulus stitching to close the disc. Or you can use another port for XT lift to put in larger cages. I think what a biportal does is really versatility. You can have more ports. You can have like some of the discussants say before, robots coming in, more assistants coming in to help you, and it's all possible. Thank you very much. Sorry, may I take more than the time that I required.
Thank you, Dr. Pang Yung Wu, for this wonderful presentation.